share the night. It goes on and on and on and on. Strangers waiting up and down the boulevard. Their shadows searching in the night. Street lights, people living just to find emotion, hiding somewhere in the night. Working hard to get my fill. Everybody wants a thrill. Paying anything to roll the dice just one more time. Some will win, some will lose. Some of them just sing the blues. Oh, the movie never ends. It goes on and on and on and on. Strangers waiting up and down the boulevard. Their shadows searching in the night. Street lights, people living just to find devotion, hiding somewhere in the night. Don't stop believing. Hold on to that feeling.
Well, I think we'll go ahead and get started now. Thank you for that wonderful lead-in with the music. I too am having a revisit to high school. Welcome everybody to session 6 of the series of 6 sessions for our Texas Hypertension Control Summit Series. Welcome on behalf of the American Heart Association, Texas Department of State Health Services, American Medical Association, and the Texas Cardiovascular Disease and Stroke Partnership to this final session of the 2020 Hypertension Control Summit Series. We appreciate this broad and engaged group of attendees with us in this first virtual summit series as we continue to grow the statewide effort in new ways. You know, this pandemic called upon us to find new ways to continue our vital efforts for hypertension control and to gather through Zoom instead of in person. And throughout the summit series, your attendance and support has made this a true success. As we move on to slide 2, we'll say for those of you who are joining us for the first time, my name is Larissa Jacobs, and I will serve as your MC today. It's my pleasure to guide you through an exciting agenda for the final session in the inaugural Texas Hypertension Control Summit, our virtual version. We're excited to recognize our clinical partners in achieving better control over hypertension for their patients to live longer, healthier lives. In my role as the VP of Health Strategies for AHA's Houston market, I have the privilege of working with a team of experts across Texas, with Heidi McPherson at the helm of this incredible work to improve hypertension control. Through the Texas Hypertension Control Movement, the American Heart Association, along with our partners, the Texas Department of State Health Services, American Medical Association, and the Texas Cardiovascular Disease and Stroke Partnership, have set sights on a shared goal of improving hypertension control. And we're seeing results thanks to your leadership. I want to thank you for taking this journey with us and for contributing efforts toward this shared goal, which has motivated and engaged so many health leaders across Texas. We are marching towards hypertension control at 70%, greater than 70% across the state, and each of you plays a key role in reaching our blood pressure control goal of greater than 70%, one patient at a time. I also want to thank the many staff from each of these partner organizations. And there are too many to list out loud here, but all of you, along with our AHA staff, without you, we couldn't have had this successful and vibrant and virtual, I might add, summit series. So for all the learnings you provided through this collaborative partnership, and on behalf of the patients whose lives will be improved, thank you. Let's see slide 3. Here is our agenda for the day. I have a few notes and housekeeping items to share before we dive in. We're so grateful to the speakers who dedicated time to sharing their work and expertise throughout this summit series, and we're thrilled to have had such strong engagement across each of the sessions over the past several months. The session recordings are available on the website, and the link will be in the chat if you'd like to return to that rich content. For today's summit, everyone except the speakers will be muted to manage background noise. So during the presentation, you'll see the speaker and the slides side by side using speaker view as opposed to gallery view. So dragging the boundary line between the two windows will allow you to enlarge the speaker or the slides for your preference. And you can find additional guidance in the chat right now. So thank you so much for the chat activity. We welcome you to engage via the chat function throughout the event. To start, please introduce yourself right here in the chat. Go ahead and place your name, organization, and get ready for our first poll questions. As the agenda unfolds, we invite you to share comments or ask questions for the speakers in this chat function, and our team will also be responding to some questions real time in the chat, so you're going to get plenty of support there. We're going to address as many questions as possible during the Q&A portions of the agenda. And with that, now it is my pleasure to introduce Dr. Eduardo Sanchez. Slide 4, yes, thank you. So Dr. Eduardo Sanchez, MD, MPH, FAAFP, Chief Medical Officer for Prevention with the AHA. Before joining AHA, he served as Vice President and Chief Medical Officer for Blue Cross and Blue Shield of Texas. There, he focused on worker and worksite wellness, clinical prevention, and chronic disease management, particularly diabetes and cardiovascular diseases. From 2001 to 2006, Eduardo served as Texas's Commissioner of Health, and in that role, he oversaw statewide public health, public mental and substance abuse disorder programs. He serves on numerous national and START boards of directors and advisory committees. So if you will activate your camera and microphone, Dr. Sanchez, the virtual stage is now yours.
Good morning, everybody. Thank you so much for what you do to address blood pressure control in our state. And congratulations to those of you who are achieving above 70% control. I see lots of familiar names and lots of familiar places as I see the chat. Let's go to the next slide. I'm going to talk a little bit about the work that we've done. And this is a series of 3 slides that I'm going to run through very, very quickly. These are levels of control. On the left-hand side, USA levels. On the right-hand side, Texas levels. And you can see that they're comparable. We're a little bit lower in Texas 2017. Let's move to the next slide. 2018, I think you're going to see the numbers get a little bit better on both sides. And in fact, Texas kind of closing the gap. Go to the next slide. And let's look at those because this is where we're at. Again, the numbers go up a little bit. The gap got a little bit wider, but we did improve. And what you could see is that we've engaged a fairly high number of people in Texas. And what I'm seeing here is about 750,000 persons that are engaged in our Target BP work. I will say that the numbers that I've seen nationally suggest that, oh, there it is, that we've got, so I was wrong, 750,000 are controlled out of about 1,126,000 individuals with a 66% performance rate. I do want to note that these numbers are pretty impressive. On a national level, that number, the denominator of over 9 million people, represents about 10% of persons with hypertension in the United States that are in care. 10% of a big number like 90 million is a big number. And so we are participants in a program that has the opportunity to not only make a difference in a significant percentage of people's lives, but we have the opportunity to grow that, that capacity. Next slide. So as y'all know, we have divided the state collectively into a number of regions. And what this slide is showing in my mind is, one, that there's some variability, but I would also say it's a what's the opportunity gap here? How do we work with East Texas and El Paso and bring that number up to 60% or above, even as we move everybody to 70%? Or above, and those that are exceeding 70% control levels, how do we keep ratcheting up? I will talk a little bit about a national goal of 80% by the year 2025, and perhaps Texas can add or have sort of a special place that we want to go to, or special recognition for those that go beyond 70 to 80% and higher. Next slide. Oh, good. There we go. So what I'm going to do really, really quickly is run through a set of slides, and I apologize, I don't see the citation there, and it should be there. It's Muntner, M-U-N-T-N-E-R, JAMA 2020. And Muntner is one of the persons who was one of the authors of the 2017 hypertension guideline published by ACC, the American College of Cardiology, American Heart Association, and a number of other organizations that were joint authors and sponsors. And that paper was one that described what has been a decline in blood pressure control in the country over the last 4 years or so. The paper looks at about 15 years of blood pressure control. The first 10 years or so increase of blood pressure control in the country. The next 4 years or so, sort of flat, and now a slight decline. But what I want to focus on today are some of the socio-demographic factors that show some variability in control levels. So first in yellow here is by age. And what you can see is that persons over age 65, not as well controlled as persons who are 45 to 74 years old. The other thing here is note that the level of control, at least of this nationally representative population, is below 50%. So that includes people who are not in clinical care. That'll be relevant in a moment. If you go to the next slide, by gender, by sex, females have higher level of control than males. That might be predictable because females generally see clinical care more than men. Next slide, when we go to race ethnicity, I think the relevant point here is that non-Hispanic Blacks, non-Hispanic Asian, and Hispanic persons in general have lower blood pressure control, hovering at about 41%, than non-Hispanic whites, which hovers at about 48%. I suspect that the percentage, the prevalence control for indigenous people, that is Native American, Native Alaskans, hovers closer to that of the non-white population that I've characterized here in this paper. Next, or that it's characterized in the paper. Next, these are social determinants of health factors. I don't think anyone would be surprised that persons with less than a high school graduation have a lower prevalence of control than folks with high school, some college, and then with college graduation being the highest. Next slide. When you look at income, again, I don't think that you would be surprised that less than $20,000 a year equals a lower level of control than persons at higher levels, and it goes up consistently in the quartiles or the 4 categories of income that are characterized in the paper. Next slide. When you look at the kind of insurance that people have, this is the one that I think captures my attention the most, where there is such a dramatic reduction. If you look at insurance status, folks on Medicare is the highest at 53.4%. Folks with private insurance and Medicaid, with private insurance, 48%. It drops a little bit for folks on Medicaid at 41%, but for the uninsured, 24.1%. And in a state like ours, which has the highest number of persons who are uninsured in the country and the highest percentage of persons who are uninsured in the country, that's a thing worth paying attention to. Next slide. And I'm going to add the next slide is about persons who have a usual healthcare facility. That level is at 48.4% control. Those who do not have a usual healthcare facility, again, it falls off. But there's a more interesting and more eye-opening statistic, and that is a person who has not seen a healthcare provider in the last year, level of control in persons with hypertension is at 8%. And I put all that out there because I think I want to, congratulate those of you who are working in settings that are providing care for people who do not have health insurance, because the challenge is great and maybe greater among that population. And it's a challenge, a universal challenge to us to continue to advocate for expanded insurance coverage for more people in Texas, and to make sure that we connect people who don't have insurance with facilities like federally qualified health centers, like county health district or hospital district clinic systems, so that they can indeed get the care that can make a difference, not only with hypertension, but with everything else. Next slide. So I'm going to close by talking about a couple of things that are happening at a national level. One is the National Hypertension Control Roundtable, which has set as a challenge to increase blood pressure control in persons with hypertension from where we are to 80% by the year 2025. The American Heart Association is an active part of that roundtable, and it is focusing on the future. COVID presented, like for us right now, a little bit of a glitch, but we are back on track and back on virtual tables to try to move this forward. Next slide. That work in some ways informed what was the U.S. Surgeon General's call to action. I think we in Texas should feel pretty great about having been doing the work that we're doing that can kind of join this call to action and be a part of this effort, not by starting today, but by having started already with a track record, and the track record that we have. The Surgeon General has identified 3 goals. The Office of the Surgeon General, making hypertension a national priority. I will say that hypertension control, I would say making hypertension control should be a national priority, but making hypertension control is a priority. The American Heart Association, and I would say, is a clearly a priority for those of us who are participating in this call and in this effort in Texas. Goal 2 is about making sure that the community places, the places outside of clinical care, are supportive of hypertension control, which includes access to healthy, affordable foods, access to physical activity, and of course, having that health insurance that then gets us to goal 3, which says optimizing patient care for hypertension control. And the work that we're doing with implementation of MAP, in some instances use of protocols, in some instances systems-based additional changes to make hypertension control a focus and a priority are about goal 3. Next slide. And for goal 1, there's 3 strategies. I think I've addressed every single one of these. Maybe strategy C is a more explicitly stated, trying to figure out how to better connect clinical services and community programs. And an example of that might be persons who get referred to, as an example, YMCA has some blood pressure control programs, linking a person to a YMCA program, linking a person to a faith-based program, connecting a person to a barbershop or salon-based program, and making sure that there's a connection between the community-based service and the clinical care service. We certainly have the technology and the platforms to make that happen. And many of us believe that would optimize the outcomes that we're seeking. Next slide. This looks exactly like the last slide. So let's go to the next slide. And this is optimizing control. So I think this really, while these strategies may not look exactly like ours, I will add strategy C. When we think about MAP, the P is partnering with our patients, and the American Heart Association and the American Medical Association released a joint scientific statement about the importance of the science of self-measured blood pressure monitoring. And what we are engaged in collectively is the advocacy around making sure that all persons with high blood pressure can get a blood pressure monitor so that they can do that work at home, manage their disease at home, and realize the several millimeters of mercury reduction in systolic and diastolic pressure that the science says happens when people are managing blood pressure at home. So I think I'm ready to close here with the next slide. Hopefully I didn't go over too much. So to all of y'all, thank you very much and congratulations.
Thank you so much, Dr. Sanchez. That was fantastic. Love the strategies. We can see so many of these strategies in action with some of our partners in terms of controlling hypertension, especially in particular between the clinic and the community linkages. So thank you very much for sharing that. You know, we've made a lot of progress this year, even through the challenges of the pandemic. So Texas has the opportunity to lead in meeting the U.S. Surgeon General's call to action on improving hypertension control. And many of you all in your organizations are helping to lead that charge in so many of the different ways, in particular, the 3 strategies that we had the chance to see today. So, moving on, we have our panel discussion with our regional collaborative chairs. We're very excited about this. We're going to shift our focus on the learnings from earlier in this presentation to this panel. We have all of the chairs, well, we have some chairs from the regional collaboratives across Texas, and it's my pleasure to introduce our 7 panelists, but I will begin with our moderator. I want to start with Stephanie Chapman, who's our Senior Vice President of Health Strategies for the American Heart Association in the Southwest region. She has a vast amount of experience with the American Heart Association. She's been with the Southwest region of AHA, starting out in San Antonio, Texas. In her current role, she oversees the strategic planning and implementation of health initiatives throughout our 6-state region. Her portfolio of programs includes hospital and ambulatory quality improvement, legislative policies, community impact, changing environments, preventative health, eliminating social influencers of health, and cardiac arrest response. She began her career in El Paso, Texas in 1999, and we're so pleased to have her here moderating. Right before I pass the baton to Stephanie, I am going to introduce each of our esteemed panelists. Dr. Shauna Nesbitt is a professor in the Department of Internal Medicine at the University of Texas Southwestern Medical Center in Dallas, where she is a medical director of the Hypertension Clinic at Parkland Hospital. She's board certified in internal medicine and is a fellow of the AHA Council for High Blood Pressure Research and a fellow of the American Society of Hypertension. Welcome, Dr. Nesbitt. Dr. Kevin Huang from the UT Health McGovern Medical School is our Houston chair. And I apologize, I meant to say before that Dr. Shauna Nesbitt is actually our North Texas chair. So I just want to loop back and make sure I've identified her properly. Dr. Kevin Huang is our Houston chair. Dr. Huang joined the Department of Internal Medicine at the University of Texas Health Science Center at Houston's McGovern School of Medicine in 2005 as a primary care fellow and became an associate professor there in 2013. He also serves as medical director for UT General Internal Medicine Center in the Texas Medical Center and University of Texas at Houston Memorial Hermann Center for Healthcare Quality and Safety. Dr. Gabriel Faz is from River City Cardiology, is our San Antonio chair. Dr. Faz is an interventional cardiologist. He is board certified in cardiovascular disease, nuclear cardiology, and internal medicine. Although Dr. Faz has a passion for interventional cardiology, he believes that combating cardiovascular disease begins with prevention, and we cannot agree more with that. Dr. Michelle Bosworth from UT Health Tyler is our Tyler co-chair. Dr. Bosworth has been with UT Health Science Center since January 2019 and currently serves as the executive director for the Center of Population Health, Analytics, and Quality Advancement for the School of Community and Rural Health. Her academic appointments include Associate Professor of Family Medicine, as well as Healthcare Policy, Economics, and Management. She is board certified in both family medicine and clinical informatics, and previously served as the Chief Quality Officer and Chief Medical Information Officer for UT Health Northeast. Welcome, Dr. Bosworth. Thank you for being with us. Joy Johnson is the Tyler co-chair. Joy Johnson is the director of Net Health Center for Healthy Living, where she supervises a group of community health workers. Together, they work to make free chronic disease prevention and self-management services accessible to higher risk individuals in Northeast Texas, and such vital work. Thank you so much, Joy, for being with us. Dr. Nellie Garcia-Blow is with Christus Spawn, Corpus Christi. She's our Corpus Christi chair. And Dr. Garcia-Blow is board certified in family medicine and geriatrics. She now practices in Corpus Christi, providing geriatric consults for older injured patients at Christus Spawn's Level 2 Trauma Center. Dr. Garcia-Blow's passion is education and improving the lives of our coastal Bend communities. She serves on the American Heart Association and is chair of the Hypertension Collaborative, aimed at improving blood pressure control in our area. And last but certainly not least, we are so honored to have Roy Champion with us, risk manager, Central Texas Veterans Healthcare System. He has been with the American Heart Association since 1986 in various capacities, including as an instructor for basic life support, he has facilitated the Hypertension Impact Grant and was part of a team that developed the national clinically validated BP blood pressure monitor list. And I know that we are all definitely using that list very frequently in our clinical interactions. So thank you for that, Roy. And he's helped with the development of check change control cholesterol, another one of our ambulatory programs. He's been actively involved with the DSH's Department of State Health Services Diabetes and Cardiovascular Stroke Council and getting legislation through the state and the National Center for Quality Assurance, HEDIS, and most recently has been the chair of the Austin Hypertension Collaborative. Welcome to all of you. Thank you, Stephanie, and esteemed panelists. I'm so excited to hear what we're going to discuss today. So I believe I am turning it over. Correct me if I'm wrong.
I think so. Well, thank you so much, Larissa, and welcome to our amazing panel. Thank you so much for your leadership and for being here with us today to share your expertise and your passion. We really appreciate it. So I'm going to jump in right away because we're short on time and we want to hear a lot from you. I want to talk about the specific needs in some of your regions. So tell us, Roy, if you will, if we can start with you and what you're doing in Austin, what are the specific clinical needs in your region and how is your regional collaborative addressing them? Do we have Roy?
He is talking, Roy. I'm not sure if you're on mute. I can see you moving.
All right, well, while Roy figures that out, I'm going to move to Dr. Garcia-Blow and ask about what's happening in Corpus Christi.
Thank you. Can you hear me okay?
Yes, we've got you.
Okay, great. Well, thank you so much for having this. I always enjoy it and feel like we learn so much from each other. Our collaborative is relatively new. This is our first year. Of course, with COVID, it's a year and a half, but I feel like COVID 2020 sort of took over. One of the first things we identified in our region was putting together this collaborative. One of the first successes that we found was just being able to connect the various organizations that we have in our community that were already doing great things, but somehow had not connected with each other. And so having this collaborative and being able to do it under the umbrella of the American Heart Association was really great for us to be able to connect the dots. And so early on, what we found was we needed more awareness. We needed more education. And so that became the brainchild behind the Know Your Numbers Day. And so one of the big projects that we worked on is February 1st, to start off Heart Month, February 1st of 2020, we did a Know Your Numbers Day. And it was a community-wide, really coastal Bend-wide, because it included our 14 rural counties as well. We were able to bring in the mayor and the city council. They proclaimed it as a Know Your Numbers Day. We had all of the news stations, all of the hospital systems, about 150 volunteers, 14 locations. We had RNs and doctors at every location so we could do counseling at the same time. And we managed to take 1,000 blood pressures and be able to put together a resource list, which in our area we found to be necessary since we have so many people that are either unfunded, underfunded, and about 70% of our population does not have a primary care physician. And so one of the greatest things that came from that was being able to put a resource list together so that once we identify a person, we know where to send them. And so that was something that we identified as a need, and the American Heart Association and our fantastic staff was able to put it together, have a big media blitz. We had little stickers that said, know your numbers, know your number. It kind of made it like a voting event. So it was on social media and everything else. And so that was something neat that came out of this collaborative that our group really felt was a big success, thanks to the AHA collaborative.
Thank you so much. I'm going to try to pivot back to Roy to see if we've figured out sound and if we can learn about what the specific needs are in Austin. All right, looks like we're still having sound problems with Roy. Apologize for that. Dr. Foz, do you want to talk to us about San Antonio and your regional collaborative's specific needs and efforts?
Sure, can you hear me?
Yes, we've got you.
So yes, thank you. I appreciate being able to join all of you to discussing, our collaborative in San Antonio. Like Dr. Blow said, this has been a really difficult year. I mean, we really haven't had much organization this year because of the COVID and being under, staying in house arrest for a lot of our patients have not really come to our clinics as far as my experience. we've had more virtual meetings than anything else. And it has been very troublesome because patients don't have blood pressure cuffs at home, so they're not really checking their blood pressures. So it's kind of hard to engage and bring them into to the clinic during these COVID times, because a lot of them are also scared coming in because they don't want to get COVID, you know, understandable. So that's been a really big dilemma for us. And so we've talked about, of course, prior to the COVID, is getting some food drives going with the San Antonio Food Bank, and also collaborating with our HEB grocery stores and other grocery stores, Walmart, to see if we could put on a healthy type of cooking classes, tips for our patients, as well as doing blood pressure checks and education in the community. Of course, that's taking the back burner for this year, but that's what we plan on doing in the future. Also getting the mayor involved. It's going to be, of course, a little more difficult since they have more priorities with this whole COVID, and but we're hoping to achieve that success in the near future.
Thank you, Dr. Foz. And so I think 2020 has definitely been very difficult in healthcare. But I hope we have some silver linings and some success despite the pandemic. Roy, I know your sound is working now. So do you want to share about any success you're focused on?
One of the big things that we've been working with here in Central Texas is partnering with the DSHS, trying to get blood pressure monitors are actually a covered benefit under Medicaid, but a lot of people don't know that. In ending 2019 into 2020, we actually partnered with the state legislature, and one of the big barriers that doctors used to complain about was the amount of paperwork it took to write the script to get it. So now we actually got that done away, so they do not have to do that whole 3-page document. You can actually write a script like you would for any other medication, and Medicaid can then take it to any DME location and get it filled. That was one of our biggest things that we've done so far. And we're still working to get that ironed out a little bit better, but that's a work in progress.
That's great. Thank you. Dr. Bosworth, what about what's happening in Tyler?
Good afternoon, everybody. So in Tyler, we have had the privilege to be able to work with DSH for the past couple of years on developing and implementing hypertension workshop programs, in which we've had about 8 cohorts totaling about 200 patients that have been impacted or at least participated in these workshop programs. And they're like a 10 to 12 week workshop program that are completely free. And it's really talking to patients about, you know, lifestyle changes and how they can better participate and engage in improved blood pressure control, not only from a lifestyle perspective, but also with their primary care physician. We also have set up lending libraries where we have different sites across the Tyler area, including some primary care clinics, but then in the community, like libraries where patients or community members can go in and check out a blood pressure cuff so they can use it at home and have that to monitor their blood pressure at home. And we are looking to expand our lending library reach over the next couple of years, as well as extend our hypertension workshop program into more primary care clinics. You know, amazingly, our highest percentage of referrals into the program are actually self-referrals by word of mouth. And so participants who are engaged in this program, then they go and tell their family members and their friends, and then they then contact us and want to participate. I've got a great team who have really had to respond to be very nimble because of COVID, because those used to be in-person classes. And actually COVID was a blessing to this program because it made us go virtual, and it actually expanded our reach to patients where, you know, some people may have had transportation issues. You know, I know Dr. Sanchez talked about social determinants, and you know, actually having in-person classes can be a barrier, just like getting to the doctor is a barrier. So I think the virtual platform, and even calling patients who couldn't even attend a virtual platform, but then calling them and talking them through the content that was covered in the class has been especially powerful. So.
Thank you. Dr. Nesbitt, what differences are there from what's been shared so far that you see in North Texas?
Thank you for the opportunity to speak. You know, I think COVID has really overwhelmed the attention span to almost every health issue in the past 6 months. And we're certainly no different than others who've already spoken on this. I think the most important piece of what has happened is collaboration, is coming together and understanding what resources are available. Where, you know, in normal times, if you're looking for medications for patients, where can you get those medications? There are some pharmacies in the North Texas area that offer medications relatively low cost or free to people who have no other resource, which, you know, even though we have Parkland to provide it, there are still some folks that don't have resources to get medications. And so locating those folks has been a real bonus. We have one of the issues that we've been able to do anyway is focusing on education. We have hosted 2 students from an HBCU here to do research and to also present their work. Just recently, they've done really nice poster presentations and received some mentoring. So these are mentoring. These are things that we can do. One of the other real issues around COVID and the effect on blood pressure control is the ability to actually do telehealth visits effectively, and recognizing that not everybody has a blood pressure cuff. How can we get them cuffs? And also, how can we leverage greater access to using video visits? Because, you know, about 40% of certain area codes or zip codes in the Dallas County area have no connectivity to the internet at all. And so that really is a major challenge around getting people to be better controlled. At Parkland specifically, and as a part of the Dallas County Community Health Needs Assessment, we are looking at specific zip codes and developing a plan specifically that will include going to those zip codes when the time is right, to host focus groups, to use community health needs, community health workers as liaisons and ambassadors and educators for the community that will help to empower people rather than to have them feel continuously dependent on the system to provide them with the education that they need. And so that is proceeding, but we can't actually get that started until, you know, we're allowed to actually have people gather again a little bit more consistently.
Thank you, Dr. Nesbitt. I know, Dr. Wong, we were so excited to hear about the $7.2 million in Houston for not only housing assistance, but broadband assistance, like Dr. Nesbitt mentioned, through the CARES Act. What else would you tell us about Houston and your specific needs and interventions, as well as success?
All right, can you all hear me?
Yes, we can.
Oh, okay, great. So great to hear what everybody else is doing, and I'll just try to touch on things really briefly here. So it was a challenge meeting across all of our diverse organizations that are part of this group in Houston, but we had a couple of good productive Zoom meetings. We kind of kept each other accountable to reaching, you know, continuing to go for the goal to to improve blood pressure control and help our patients in all aspects of their lives. And a couple of areas that the organizations talked about were, how to continue measuring blood pressure in the clinic when it was appropriate, and how to help people measure blood pressure at home, especially during COVID, when patients were at home. We shared tips on how we could incorporate telemedicine better into our clinical flow, not just for blood pressure control, but just for overall, visits that had anything to do with cardiovascular health. A couple of topics we talked about were, helping to maintain patients at home by making sure that they had the medication refills that they needed, doing our best to help them out to get blood pressure cuffs at home. All of this is a challenge, as many others on this call have noted. And then at our own institution here at McGovern Medical School, we've seen just more activity with our healthcare team in doing a more targeted job at assessing social determinants of health, whether it be access to food or transportation, or even going deep into things that affect mental health, like interpersonal violence and other things that may, tangentially affect not only blood pressure, cardiovascular health, and also just overall health. So a lot of y'all have done great work, and I just want to add some of the other things that we've been doing here, and it's great to be part of y'all's group.
Thank you. Dr. Bosworth, let's go back to you and talk about what kind of policy and systems changes you'd like to see in your community or across the state that you think would be effective for improving hypertension control.
Well, I want to kind of echo something that Dr. Nesbitt was talking about in terms of connectivity. And, East Texas is very rural. And one thing that COVID and telemedicine has really highlighted is, our connectivity issues and reaching those patients who are in those rural communities who may or may not have really good internet access. And I really feel like that is one of the key solutions to a root cause of getting patients access to care. We can do so much, as what we've seen already with telemedicine, and especially in rural areas. I would love to see something more, policy-wise for connectivity. This is a pipe dream, but wouldn't it be great, if internet access was a DME need, in terms of how do you get connected to your cardiologist or your primary care physician if you're in deep East Texas and there is no primary care physician within 200 miles of you. So anyhow, so that's kind of, maybe out there a little bit, but I think that's a real part of the conversation. The other aspect, I think, especially with East Texas, I've been in East Texas for about 12 years. I moved here from Asheville, North Carolina, where I did my residency. That is a very active community in terms of lifestyle, health. And when you come to East Texas, it's a donut shop on every corner. It's fast food. The built environment, the community is not, these communities, they're not culturally or logistically developed or built for health and to promote health, healthy lifestyles. And I feel like that is a huge problem. We've got, tons of land and rural areas that could be great for biking and running and jogging and walking. And it took COVID for me to actually see so many members of my community actually out on the walking trails now, because there's nothing else to do. And so anyhow, so I just, I would love to see more of our built environment that's focused on lifestyle changes, because that is root cause of, hypertension.
That was certainly been a silver lining, seeing more and more people out exercising. Dr. Foz, do you have additional policy or systems changes that you'd like to see?
Well, I think, as someone echoed before, I just want to echo what someone said before, as far as Zoom has been and will continue to be instrumental and transformative in how we communicate with one another. Now, it's not going to be like, meeting in groups anymore, but more like virtual kind of meetings, because I think it's more productive as well and in a lot of areas. So I think that's going to be very important. I have issues, of course, with getting a hold of patients Zoom, because in my population, I think as you guys may experience, they don't have access, so a lot of it is also just via telephone, and trying to get a hold of them that way. But, of course, when you're doing a physical exam, there's nothing like person being present, except because, of course, if it's a follow-up, I'm hoping that, lifestyle will change for these patients as far as being able to exercise more. I've seen a lot of that with my patients as well, because there's nothing else to do. But then they're eating a lot more too. So it's kind of a different balance. So I'm hoping that we can learn something from this year and take some positives out of that, and like I said, turn into a positive.
Great, thank you. So we've just got a couple more minutes, and I want to touch on collaboration because we've talked a lot about the social determinants of health and the needs in your various communities that really align. But we know that the most successful changes are broad, multi-sector collaboration. What recommendations do any of you have to foster meaningful and sustainable collaboration across your collaboratives, across the state, to go into 2021 and beyond? And I'm going to open it up to anyone.
One of the things that we could do, and it's really an underutilized resource, is the CAPE programs with public education. We actually have programs, for example, HOSA, Health Occupation Science Association. These are public classes that teach high school students about what is an HMO, what's a PPO, how to do access. We actually train students to go out and be medical assistants. When you look at a lot of your patients in your social, excuse me, when we look at the social determinants of health, how many of them have food insecurities? And yet there are CAPE programs that deal with nutrition, and they actually collaborate with each other. So for example, when I was teaching in high school, we actually had the HOSA group talk about different foods, different availabilities. Well, the FFA group actually grew some of the different herbs, and then the home ec class actually cooked them, and the students were able to try it. Then we had the media classes actually created a little cookbook that the kids could take home to their families. And when you think about how many patients in these rural areas are migrant workers, have limited access to wherever, the one thing they all do have is a public school. You're going to be pretty hard pressed to find anywhere in Texas where that isn't available. And right now, with the focus on education changing, how are we going to do these educational opportunities? There's a beautiful area for that. Even with the internet, think about Austin is going out with public schools and setting up internet in communities for the students. It would not be a hard stretch to say, hey, look, by the way, can we piggyback off of this and use this for these other areas?
Thank you so much for sharing that, Roy. And, this time went so quickly. I would like to spend the rest of the day talking to you all and hearing about your experiences, but we're already a few minutes over. So unfortunately, we've got to close. I just want to thank all of the panelists so much for being here today and for sharing. So I'll give it back to you, Larissa. Thanks so much.
Thank you so much, Stephanie. Wonderful job to the panelists. Agree with Stephanie. We could talk about this forever. It is so interesting, but it is time for celebrations. So I am actually going to, as we move to the next slide, turn it over to Dr. Sanchez. Dr. Sanchez, please return to the digital stage. Maybe you're here and I can't see you. Yeah. And we are ready to kick off the recognition and celebration.
All right, awesome. That was an awesome panel. And I just can't say how proud I am to be a Texan, live in Texas, and know that this is the kind of work that's being done. And I think that collectively, what I heard was we need to work together to affect some policy change. And I certainly look forward to that, and AHA looks forward to that. We're going to recognize fan favorites from last month's poster session. From the great slate of posters presented, one poster from each of the 3 categories was selected as a fan favorite. First category, data-driven hypertension initiatives. The authors, Singleton, Adams, Steele, and Gimple. I hope I pronounced that correctly. Title, Developing a Data Map to Implement Community-Based Intervention for AHA Blood Pressure Cuff Loaner Program in Dallas, Texas. Next category, Community-Based Hypertension Control. Authors, Steele, Adams, Singleton, Gimple. Sound familiar? Title, Community Intervention to Promote Self-Monitoring Blood Pressure. And then last category, Leveraging Technology and Clinical Engagement. Authors, Williams, Nordheim, Thornton, and the title is Adapting Self-Management Program to a Virtual Platform. There's a theme here, and again, I think it's a reminder to us that this blood pressure control business is a system challenge, a system solution-based challenge, and congratulations to those fan favorites. There is a place where you can link to the posters, and I believe that information is on the slide. So I'm hoping that we are progressing, and what I want to do now is recognize those practices that have achieved, I'll use the term awesomeness, a nice technical term, and while I'm stalling with words, I'll try to figure out how to get the view so that I can actually read the things that are on the slide. So gold, exceptional practice. So let's see, those are in recognition for achieving 70% or greater blood pressure control among adult patients. Here they are listed. I'd love to read them because I love to read these names. You can see that there's a nice swath across the state that are covered. And congratulations to all of y'all. Exceptional, it's what we do. So that was really fast, and there's like a minute left. Let's go back and just sort of let people look at those names one more time. Go to the first slide, and let's look at those, and I'll just talk about it a little bit. So here you got Houston participants, a boatload of them, and it continues. And then we go to the rest of the state. Oh, here we are. I guess this is showing us the categories. I apologize. So I will say we've got a new category coming up. That's Gold Plus, that attests to evidence-based blood pressure activities. That's the importance of data, and data, quality data that is more than just self-reported data. And the silver category, I think, is a critically important one to point out for next year for our target BP participants who are doing the structure and process pieces and putting them into place to achieve gold. And you can see that silver designation is going to be about committing to improving blood pressure control, submitting, and that involves measurement, submitting data and attesting to evidence-based blood pressure activities that are delineated in the description of the description of how to get silver status recognition. I'm going to stop there in the interest of time and say thank you so very much. This enterprise of improving blood pressure control, as all y'all know, it's a means to an end, and that end is to prevent heart attacks, strokes, heart failure, chronic kidney disease, and a whole host of other things that blood pressure leads to and or contributes to, including premature death and premature disability. So back to you, Larissa.
Thank you so much, Dr. Sanchez. Well, this was fantastic. What a great day. We do have our photo session coming up for those of you who have registered. I do want to be mindful to, and I just put it in the chat just in case we ran out of time, looking toward December 31st, I want to be mindful of just letting everybody know which of these 4 to 6 4 of these 6 strategies is your clinic able to commit to. And by doing at least 4 of these, you'll have your clinical site eligible for the new award levels of the Silver and Gold Plus. So a little bit of a mouthful, but glad that we got to present that to everyone. So I think that the link is in the chat. So if you'd like to know more. And finally, we look forward to working with all of you in the coming year on systems innovations and policy changes to further improve hypertension control across Texas. Something that we would like for you to consider doing right now, be sure you and all of your team members are registered for the Target BP newsletter. I know that I read it and I get so much out of it. Sometimes I'll go back and reread it twice, 3 times. Watch for the invitations for the regional collaborative meetings, which will be held in early 2021, virtually, of course. This concludes the formal sessions of the 2020 Texas Hypertension Control Summit Series. For those of you who have pre-registered for optional award ceremony, for the photo opportunity, of course, we ask you to log into that separate meeting link right now, and I'll meet you there. You have the link in your email. Please be very prompt about joining. And yes, rah, rah, Texas. Just a big thank you so much.